I forgot to ask. I've been trying to get the screen up. Can't do it.
Hello, everyone.
Hello.
Thanks for joining for the Alaska Project Echo Dementia. We'll get started in a couple of minutes. Just give everybody a little time to come on. It's not yet noon Alaska time. But we will start exactly at noon just because we want to be really respectful of your time.
Hi, it's Barb Bigelow. I've joined by phone as well. Thank you.
Thank you. It's now 1 o'clock, so we'll get started, and we hope that everybody had a lovely week, 3-day weekend last week, getting some rest and relaxation and enjoying that time off. Okay, I'm going to start sharing my screen if that's okay, Mary. Okay, so welcome back to our Project Echo Dementia. We're very, very happy that you're here today, and we hope that this information, that we can share our learnings with one another and we can provide information that's useful. Today, we're going to really focus on a range of pharmaceuticals that are associated with dementia treatment, and including those for psychological symptoms and behavioral management as well. So we have our hub team here. We're not going to take time for introductions because we only have an hour, but you see here is our hub team, and we have CME Credentialing, so please do fill out the survey for accreditation for your CME. The hour is worth 1 credit. And as a nurse, you can also fill out and complete, or nurse practitioner, the CME as well. Here are our disclosures. All relevant financial relationships have been mitigated. The following planners and speakers have no financial relationships to disclose, as you see. And here's the number actually that you'll use. We can enter this in the chat to complete the evaluation and receive your CME. Okay, so briefly, we're a learning collaborative. We're learning, it's all teach, all learn in the spirit of democratizing knowledge, which is really integral to the Project Echo process. All of the sessions are recorded and available on Mountain Pacific Quality Health's website. We have a lot to learn from each other, and you guys have a lot of wisdom and experience and education from caring for people in communities in Alaska. So please bring that forward as well. If you can, we'd like to see you on camera. We understand that may not be possible in all cases, but please do share your video. So for today, really our objectives are to describe the potential benefits and identify 3 common side effects of cholinesterase inhibitors. And as you all the cholinesterase inhibitors are a class of medication that we're going to discuss further and have been used as a symptom symptomatic treatment for the cognitive challenges that are experienced in dementias. And then the second objective is really to identify very clear reasons and rationale to use atypical antipsychotics in the case in a person who's living with dementia. Okay, so I will launch into the talk. So just to take a sort of step back in a way, we've talked a lot about what an age-friendly health system is and how this, through many people who are career scientists in geroscience, these are these domains that have been identified as improving outcomes, improving value, and really being patient-centered, really at all ages along the health span, but in particular for those elders. And so just to underscore this within the context of dementia care, you know, dementia care is whole person, and I would say family-centered care, which is the person who's living with dementia and that care provider, that family member, that care team. We know that dementia care can be very complex, and we also know that sometimes it's the most kind of simple, grounded interventions like tone of voice or letting in light during the day that really can have a tremendous impact on quality of life or well-being, sense of well-being. And then really remembering to incorporate those 5 M's that can guide and shape the care that you're offering or you're serving to people living with dementia in this, so that it's consistent and comprehensive. So just reviewing those again, you know, how you might implement this, what matters fundamentally to the patient and to the care team, what matters around goals of care, advanced care planning, are the basic needs being met? Are we engaging with the person in the community? What is the faith community context? And really thinking about and re-examining what matters, because that shifts over time as multimorbidities or hospitalizations or other issues, or just time actually can you know, cause progression in the neurodegenerative course of the disease. And then, you know, mobility, let's see the walking, let's make sure that we look at frailty and look at walking at every visit, and then connect to resources like the National Institute of Aging resources around exercise, including balance and strength training and aerobic exercise and stretching. And then making sure that the home, you know, is safe. Are there rugs on the floor? Do people have grab bars if they need them? Is there a shower chair, and so forth? And really making sure when we're thinking about mentation that we're thinking about it broadly in terms of both brain and mind health. So addressing isolation or loneliness, which we've talked about before, really making sure that we're doing at the annual wellness visit and subsequent visits a cognitive assessment through a validated instrument. And I'll refer you back to the excellent talk that Dr. Rhodes provided around timely and accurate detection of dementia. And then, you know, are people, what's their goal in terms of where they want to age? In place? Can we make that comfortable and safe and supported? And then what we're going to talk about today is medications. You know, how can we simplify the regimen? Are there medications that are potentially harmful? What's the adherence like? Can we reconsider? Might we try to taper something down? And so forth. And really looking at those very, very, very carefully, including over-the-counter and herbal remedies, and then when to think about deprescribing in terms of the risk-benefit ratio for medication. And then the 5th M that Providence has added, which I think is critical, and which Hippocrates spoke about in terms of let thy food be thy medicine and thy medicine be thy food. You know, what is the patient's diet looking like? So, you know, are they implementing, and we've talked about old ways, which is a link, we can put it in the chat, around diet that is culturally, you know, within somebody's cultural heritage, but which includes lots of fruits and veg, limits processed foods that can be harmful, not only to dementia and accelerated aging, but to diabetes and to heart disease and to kidney disease and so on. Okay. So I want to point you towards, in the service of time, very briefly, this thinking about this, using this communication tool that was developed by Mary Tinetti at Yale. And I've put here the link to the Patient Priorities Care site, and both patient-facing materials, and then how to facilitate these conversations. And this is very well aligned with 5M, but what it really does is it helps to promote a discussion in the office that helps to identify and support the priorities that the patients have. So, you know, what matters most? Let's get actionable, specific, and realistic around health outcomes. What are the preferences in terms of risks and benefits? And then what's that one thing, you know, that the patient really cares to discuss at that moment? And so here, this is another way to talk about it in terms of medications or self-management or supportive services, or even a test, you know, that you may think is indicated, but which may not be a priority for the patient. And then here, the person with dementia, you know, these are sort of an example of what's very, very, you know, green, go to first, yellow, think about next, and red sort of in the stop light fashion, really coming later in the game. So here is a person who's living with dementia who has, you know, you need to have interventions for cognitive symptoms and maintenance of function, interventions for non-cognitive symptoms and challenging behaviors. And then what about interventions for comorbid emotional disorders? And as you see here, I mean, across all these domains, the non-pharmacological interventions are things that we want to make sure that we're doing hand in hand with our other interventions, because they are safe and as you'll see by the evidence, you know, quite effective in many instances. And then we'll think about pharmacological interventions as well, drugs for Alzheimer's disease and other dementias, you know, pharmacological interventions for the management of behavioral symptoms, which we'll talk about, you know, and then if somebody is really unsafe to him or herself or to the care partner, what other medications that we might, you know, still really have only for those urgent moments. Okay. So there are no disease, I would say at the current moment, there are no disease modifying therapies still that are effective, safe, and affordable for the treatment of Alzheimer's disease. In quite some time ago, 1996 now, you see there was the first cholinesterase inhibitor that was approved for the treatment of Alzheimer's disease. And that is Denepazil. So these medications work by slowing down the breakdown of the neuromodulator acetylcholine, which is a neuromodulator that helps with attention and memory. So we make this acetylcholine in the basal forebrain, and then it comes and it has these pathways throughout the brain, including the limbic structures that are important for memory and also the neocortex. And so it's a very important neuromodulator for attention, memory, focus, and engagement. So the cholinesterase inhibitors slow down the enzyme that breaks down this neuromodulator. That's how they work. And however, the side effects have a similar effect, which is that they slow down the breakdown of acetylcholine in the peripheral system, which, as people may remember from their, you know, training, can cause all sorts of side effects, like increased urination, GI side effects, lightheadedness or bradycardia, and so forth. And we'll talk about that a little more in a moment. But so you have the benefit, the potential benefit, and then you have the on the other side of the scale, the side effect profile, which is the peripheral cholinergic effects. So Denepazil was the first medication that was approved. As I said, it's available in 10 milligram tablets, and you start with a half a tablet. It's also available in 5 milligram tablets. I usually start with a half of a 10 milligram tablet for a month and then go up to a full 10 milligram tablet just to titrate slowly. Common side effects for Denepazil, we'll talk about in a moment. Rivastigmine was also approved in 2000. The generic name is rivastigmine and the trade name is Exelon. This is also approved for mild to moderate stages, and the benefit for rivastigmine is that it's transdermal patch as well. So if people cannot swallow, or if they're NPO for surgery, for example, they can continue with that medication. And then galantamine was approved shortly thereafter, also for mild to moderate disease, and in a solution, in an extended release, and an immediate release. Of these, the only one that has approval for mild to severe stages is Denepazil. Okay, so this class of medication is approved for mild to moderate, and Denepazil is approved for mild to severe. The NMDA antagonist memantine, which was approved in 2003, as you see here, is approved only for moderate to severe disease. Now, some people cannot tolerate the cholinesterase inhibitors because of the peripheral cholinergic effects. And so in that case, sometimes you may use empirically an NMDA antagonist, and we can talk about that later. And then in 2014, there was a medication called Namzaric, which is a combination of Denepazil and memantine, which was approved for moderate to severe disease. And there's some controversy as to whether that combination is superior to either alone. And the data is a little mired there. So in terms of the severity, symptoms, and treatment, if somebody is not demented, okay, then there's no indication, there's no FDA approval or indication for treatment with cognitive enhancers, such as cholinesterase inhibitors or NMDA antagonists. Now, NMDA antagonists, the memantine is now used for headache as another approved use because it's been shown to be beneficial for migraine. That's a separate discussion, but I just wanted to acknowledge that. In MCI, or mild cognitive impairment or minor neurocognitive disorder, there are no current FDA approved treatments, okay? Okay, so in mild dementia, we talked about the cholinesterase inhibitors. In moderate, we talked about the cholinesterase inhibitors and the NMDA antagonists. And so how do we phase the disease? So let's remind ourselves. So in mild cognitive impairment, as distinguished from dementia, functionally people are doing okay. So they're able to care for themselves, they're able to drive and shop and pay their bills and those kinds of things. Whereas in mild dementia, they can no longer manage their, what we call instrumental activities of daily living, such as their finances, such as traveling or driving or those kinds of things. And then in the moderate stage, there may be more neuropsychiatric symptoms, basic ADLs become impaired, and then severe, really the most basic activities of daily living are impaired. And in advanced dementia, there's no randomized control in the staging of Alzheimer's or stage 7. And in this case, in stage 7, really there's, problems with ambulation, the person is virtually mute, and there may be dysphagia very, very commonly as well. Okay. So let's talk about the adverse effects of the cholinesterase inhibitors and the NMDA receptor antagonist memantine. Okay, so as we said, the peripheral cholinergic side effects, here we go. These are the peripheral cholinergic side effects. So the GI side effects here, the fatigue and syncope is because of the bradycardia. So, you can see them, it's a class effect, right? So you see them in all the medications. However, there is some indication that the transdermal patch preparation of rivastigmine bypasses the gut and therefore has less of these very common, nausea effects. Okay. Some people get really bad diarrhea, so you just have to talk with family kind of to set the expectation around the care. And then with memantine, on the neuropsychiatric inventory, so the primary outcome measure for the prospective trials was looking at cognition. The secondary outcome was the neuropsychiatric inventory, and what they found was that people who took memantine felt calmer and had less kind of irritability and agitation. This is not the case, however, for everyone. And in some cases, you can unfortunately see a little more of the agitation in starting the medicine. So you just need to be careful and educate the family so that they know what to look for and when to talk to you. The memantine is also started with a titration dose. It's a 10 milligram tablet, and you start with a 5 milligram once a day for a week, then twice a day for a week, then 5 milligrams in the morning and 10 at night, and then 10 and 10, which is the standing dose. Okay. So now, where are we with regard to the management of behavioral and psychological symptoms in patients with Alzheimer's disease? So there was this consensus panel that came together to make these recommendations in 2019. And here's the recommendation. You'll see, let's think about this in terms of the whole patient-centered perspective. What might be causing the symptom? Let's help work with the environment and the care team to resolve and educate around de-escalation or approaches. Let's tailor a program, maybe a serotonin medication such as citalopram or escitalopram. Are they experiencing pain? And very, very, very down on the list might be an antipsychotic. Okay, and then there's similarly some recommendations around approaches such as the DICE approach to really unpack, to determine what's going on, to investigate that, to kind of consider how to approach that, coming up with a very implementable plan, and then to evaluate or reevaluate how effective that intervention is. And then there's some, less information. There's a very small pilot study, which I cite here, using the dextromethorphan and quinidine for patients. And it's a small trial, but there was some benefit you see published here. And then, Remeron or mirtazapine can be helpful. Prazosin, there's small studies. Okay, what about antipsychotics for dementia? So this was a big evaluation done by Cochrane in 2021, which is a meta-analysis. And I'll just read the conclusion. Some evidence that typical antipsychotics might decrease agitation and psychosis ever so slightly. Atypical antipsychotics like quetiapine, like olanzapine, like risperidone, reduce agitation and dementia slightly, but their effects on psychosis are negligible. And the apparent effectiveness of the drugs seen in daily practice is maybe explained by, we don't know. It's kind of like, we don't know the answer. So because you can see this changes in the natural history of the disease, also in the placebo groups. We know that it can increase somnolence, and other adverse events like cardiac arrest. So if we are considering antipsychotics for sedation, it's only in the context of somebody who's at risk to harm themselves or really significant suffering. And then really talking that through with the patient and the family member, and weighing the risks and benefits and having tried other approaches. But if somebody is suffering, understanding that there are staffing shortages and many challenges, and if they're potentially at risk to themselves or those around them, it may be something that you would incorporate for a short time. Okay. So this is just to kind of imagine for a moment, take a breath. If you can't really articulate what you're feeling and you're feeling angry or scared or overwhelmed or frustrated, all these things, you might not have the most skillful way of expressing it. So also trying to bring the most compassionate approach when addressing these symptoms or these kind of expressions of suffering. So that, the first steps would be a medical evaluation. Is there pain? Is there constipation? Is there infection? Let's look at the medications. Was something started like an over-the-counter Tylenol PM that has Benadryl that's making somebody really agitated? Or were there drug interactions that are making somebody more sleepy or confused? Are they wearing the hearing aids or the glasses? Do they need cataract surgery? Is there a sensory deficit that's really making somebody frustrated? What's the behavioral history? What feels good? What soothes the patient? What brings ease? And then what kind of interventions, non-pharmacological, might we consider? Okay, another meta-analysis through the Cochrane database, and these are massive meta-analyses. So just antidepressants for treating depression in dementia, very, very variable, basically no or little effect. So there's, we don't have science to support the treatment with medicine. In the case of depression in dementia, there's far more evidence for other approaches. It's not to say that you don't use an SSRI, and you may have experience where the SSRIs are effective and you start low and you go slow with, for example, escitalopram 5 milligrams. But in this meta-analysis of many papers over time, there really wasn't significant benefit. So this is another article that just came out in British Medical Journal, comparing the efficacy of interventions for reducing symptoms of depression in people with dementia. So it's a systematic review and network meta-analysis. And, there's a theme here that we are all of us, I think, kind of noticing around these approaches that are evidence-based interventions. So such as reorienting or the reminiscence therapy, where, there's any activity to remind people to savor the past, or cognitive stimulation that's gentle and supportive, that's reorienting, or art therapy or games, or how can we modify the environment so somebody knows when it's daytime and when it's nighttime and we're not interrupting them overnight, or gentle touch or massage therapy, making sure that somebody has the maximal mobility possible. And then, the interactions that are really cued into the needs of the patient and the emotional expression of the need of the patient rather than the literal, expression, which sometimes cannot capture that emotional experience because of the dementia. Okay, and then continuing with exercise, which can help metabolize some of that stress or energy, making sure that there's a team approach. And, pet therapy is like the best for most people because there's this oxytocin rush with soothing and connection and just that loving, loyal presence. Okay, so this is a kind of a busy description of how depression and Alzheimer's disease can flow back and forth with one another. So certainly it's very important to identify and to treat depression, in midlife or earlier, and also throughout living with dementia. If you have untreated depression, that can accelerate aging and can affect areas that are vital for learning and memory, and that are also implicated in the neuropathogenesis of Alzheimer's disease, specifically in the hippocampus. So there's problems with neurotransmitters and inflammation related to the depression and the sort of stress and back and forth. So they can it can accelerate aging and lead towards an emergence of Alzheimer's disease. And in Alzheimer's disease, you can have more neuropsychiatric symptoms, including depression. Okay. So how can aggression, be caused? So factors that can cause aggression, we've talked a bit about this, if somebody's afraid, if they're uncomfortable, if they feel rushed, if there's lack of structure in the day, if things are too loud, if they're delirious or frustrated, or the caregiver, if we don't have the skills and we're inadvertently challenging somebody in a way that's not supporting their needs. Okay, so we want to try to identify the triggers, ask who, what, where, when, how. Was there a recent change in medication, environment, routine, caregiver, roommate? What are the nonverbal cues that we can read if somebody's not able to tell us? And then, how is the caregiver, is that care partner feeling nourished? Is that person getting away, getting the support that he or she or they need? Okay, and we talked about this as well. And how can, we can really help with that by providing the support and the structure, by trying new things such as medication, such as different approaches in the environment, or these types of reminiscence therapy or pet therapy or other therapies. And then connecting, of course, to, the Alzheimer's Resource of Alaska has incredible rich resources, both in terms of education and programs and services that we'll hear more about in subsequent talks as well. So really making sure, and then anticipating, what to expect. And sometimes role playing in the office around how to kind of manage those expectations can be really helpful too. We've talked about this a little bit more. We've talked about kind of how to correct these things with structure and patient-centered care, and then how to de-escalate, if somebody is like you're picking up on their kind of getting a little bit agitated, to reassure, maybe give them some space or reorient. Is it time to maybe listen to music or have a cup of tea or slow down, and have that sort of opportunity to really gently connect. Okay, and this I just thought I would add because I gave a talk last week on delirium, but there's this big, we want to try to avoid delirium, and delirium is certainly a time when the agitation and the behavioral challenges can really manifest and get tricky. And so, identifying that and managing the underlying condition and really trying to have a team-based approach can help to improve quality of life as well. There, I just refer you to a talk that I gave last Friday with our ECHO in Washington, because it has much more detail on this. But this is just an approach that we're trying to take, which may be beneficial for anybody who's living with dementia in terms of the risk of delirium and the number of cases which are preventable, to try to kind of identify those folks at high risk, to screen for those individuals, and to get in a comprehensive team-based model of care to improve outcomes in that setting as well. And then I just thought I would have like one slide on aducanumab. So as people may know, aducanumab is a monoclonal antibody that's targeted against amyloid. And this is used for the treatment of Alzheimer's. It was FDA approved against a lot of scientific recommendations. It's cost prohibitive, it's dangerous, and I'm not sure that it's effective. There's a lot of debate in terms of whether it's effective. In 40% of cases, you can see these amyloid-related imaging abnormalities, including edema and bleeding, as you see here, that are not unlike the spontaneous events that can happen. I'm happy to talk about that further, but I just felt like I would acknowledge that there is a current therapy which is now being considered by CMS, and CMS has recommended that it only be used for people who are participating in clinical trials because more data is needed. Okay, so above all, you know, what we want to try to do in these patients with anything that we use in our medicine, you know, kit, we want to sort of seek to understand and to ease the way. Okay. So maybe I'll stop sharing for a moment and to see if there are any questions in the chat. Yes, thank you. And they indeed, thank you for adding that, you know, and they absolutely all, the atypicals and typical antipsychotics all carry black box warning of, you know, increased mortality in the elderly. So thank you. Any questions about these medications, or anybody want to share an experience that they had with any medication? I see Luann. Oh,
No, go ahead.
I was going to say Luann has beautiful blueberries, but I don't, would anybody like to?
I'll share.
Great.
Okay. As far as medications, you know, I was a family caregiver for my dad, one of many family caregivers for him when he was living with dementia. And towards the end, he was diagnosed with Alzheimer's and Parkinson's, and he was given a lot of different medications. And we noticed towards, I don't know, maybe it was kind of the moderate to late stage, he started having trouble swallowing. And it was just a fight to try to get medications down him, you know, because he just would, you know, it would end up, you know, it was just really hard for both of us, you know. And so we decided as a family, we asked, you know, the provider, would it be okay if we just, you know, just stop those, because they don't seem to be they seem to be making things worse at this point. And he said he thought it was a good idea. And, you know, since we were the ones who were caring for him every day and different things, and we'd see, you know, how he reacted to things. And that was one of the things that would really be upsetting. And so we ended up not, you know, taking him off the medications, and things were a lot better then. I mean, like, you know, as far as he was still declining and everything, but it wasn't, I don't think it was making that much of a difference. I think it was just hard for him to, at first we tried to like crush the pills, or, you know, the ones that could be crushed, and stick them in yogurt and things like this. But then even that, you know, it became harder and harder. So that's just, I wanted to share that. And also in my work, I've heard of a few different examples of medication where, like, I remember one caregiver when I was working in Anchorage talked about her husband being on, you know, at first when he got into assisted living, he got a little bit combative and things like that, you know, and so they put him on medication, and she talked about how hard it was, because it seemed like it was too much. It was just really hard to balance that. And I remember, because either he would be very upset or then he would be just, like kind of comatose or something. There was just those two opposite spectrums. And I remember seeing some people that I worked with as well, both in some of the groups that we always would know when they were, like on medications, because it seemed like there was never a middle ground or whatever. It was, all of a sudden the person would just become very, just where they're not able to engage or whatever. And it was just kind of sad in a way. So anyway, I just wanted to share those.
Yeah, thank you so much for those reflections. I mean, I think that that illustrates very clearly what I suspect many of you in our community have witnessed as well, in terms of, as somebody progresses, the benefit may not be there over time. And so Kyla's going to present in a moment some cases around deprescribing and how to go about that, and some wonderful resources around that. And then the other observation that you made, Kim, which I think probably many in the community have noticed and seen in their own practice or their own experience as well, is that sort of moving back and forth between agitation and oversedation. And oversedation, of course, can increase your risk of hip fracture and fall and aspiration, and infections and all sorts of things. So how do you work with and advocate for and problem solve around an approach to minimize those risks and, to minimize the suffering or to maximize the thriving in those patients who have moderate to advanced dementia? So it's very hard. And sometimes with medication, it's really, medication is the later, it's the team approach, and all those other things are what we want to implement along with, potentially medications. And then in terms of what you would try first, as we discussed, maybe a serotonin medication like an SSRI at a low dose, which can really sometimes help with agitation and impulsivity as sort of the first class that you might consider. So then Karen is saying here, as a family member, transdermal administrations would be very helpful. And thank you. And the one thing I'll say about that, and it's just really important for all of us, is that, you can shower with it, you change it about, 24 hours, you don't put it on the same spot. And you want to be careful when you take it off, that like you would with a Band-Aid, you just want to take a little warm water and a little soap and just with a washcloth kind of go over that where the adhesive may have stuck, because otherwise people can have an atopic kind of dermatitis, they can have a little allergic reaction and they can have a welt in that area. So the transdermals that you change once a day can be really a great way if somebody has trouble swallowing or they don't want to take pills, and they're tolerated quite well. Apart from that's the main common effect, is that little rash around the area. So let's see here.
Actually, this is Gay. Can I make a comment?
Yeah.
I just put in the chat a thing about Dr. Adam Power's book on Dementia Beyond Drugs. He was up here several years ago for one of ARA brought him up along with some other folks, and he gave some very interesting stories about his own progress as a physician. That he realized at some point he was getting called by nurses and by family members and things, but mainly nurses in facilities, and saying, what should we do? We've got this person that's really agitated, And he finally realized that all he had was medication to give them, and that it doesn't seem to really work. He would try out different things and they'd still stay agitated or whatever. And so he took the time to go in and actually talk to some of the clients, some of the patients, and began to really realize that the main thing that needs to happen is this thing you were talking about, is the non-pharmaceutical approaches. That yes, there are times when some of these medications, but his book is really quite an eye-opening book I found that to be true. And so I try to recommend that to when I get family members or anybody to say, hey, take a look at this book. It doesn't mean you don't use it. And then another presentation we had a couple of years ago, it was a combination between Teepa was there for one day.
Right.
And then this, I don't know how many of you remember that. And then the second day was a psychiatrist. And he was pretty adamant that saying, hey, you guys are not, if all you're doing is a non-pharmaceutical, you're missing the boat. But he said that you really, what I got out of it anyway was that it is a balancing act, and we don't want to throw out the meds, but we need to be very, very careful.
Yeah.
And really do our assessment.
Thank you for, very, very well said. And I wholeheartedly agree with that. And we want to use whatever we can to help the individual who is, in pain, psychic or otherwise, of course. And Kim has training, and maybe others do an ARA, with Teepa Snow and inpatient education and resource. And that's a wonderful resource in Alaska, because I think it is often, and I can't say always, but often really enough, as we've been talking about, and something you would certainly try first. Okay, so let's now continue with the case presentation. Thank you, Kyla. So we're very fortunate to have Kyla Newland, a PharmD in Alaska and with Mountain Pacific Quality Health. Thank you, Kyla. Just let me know when you want me to go to the next slide, or if you want to share your own slides, either way.
I'll go ahead and have you share them. Thank you.
Okay,
so
yeah,
much.
of course.
I do see a question in the chat asking about Seroquel for agitation. I don't know if I know you in your presentation, you addressed that a little bit. Do you want to speak to that, or?
Sure. I mean,
I
can speak to it briefly. I mean, as I said, we, sometimes people have been tried on everything, and I want to be very sensitive too, as I acknowledged, we don't want this sort of rigid, there's no science to demonstrate that these medications help on the one hand. On the other hand, there's these studies take time, and they are, Seroquel of the atypical antipsychotics is more sedating and less potent than, for example, risperidone or olanzapine. So that is frequently the one which is used in the elderly first. And also, people who have Lewy body dementia, you can get a really bad extrapyramidal reaction, meaning very Parkinsonian with a very low dose of an atypical antipsychotic. And Lewy body dementia, as people may remember, is the second most common neurodegenerative cause of dementia in the elderly. So we want to be really careful if somebody's having visual hallucinations or they're at all Parkinsonian to never use the atypical antipsychotics, because they can harm people even more than they're already, with their black box warning, potentially harming people living with Alzheimer's or vascular mixed. But if you have an instance where you're trying literally everything, and nobody's sleeping in the family, and the person is at risk to harm themselves or their family members, can we sometimes use a little bit of this atypical antipsychotic to help people to feel safe and calm, like they need a sedating agent? That's an art of medicine judgment call, where the answer is maybe. I'll go that far. Yes, to if the person's really suffering and that's all that you have, if you've tried literally everything else and you need something in that emergency setting. Okay, Kyla, and you may have more to say from your perspective too. As a pharmacist who really helps take care of these families with complex challenges.
Yeah, I like what you said about kind of balancing that. The dopamine is what those drugs work on, and then we know that can aggravate Parkinson's disease, and it's kind of like this balance between too much dopamine and not enough dopamine. And then, as you spoke about earlier, it's also the acetylcholine, balancing that with the acetylcholinease inhibitors versus the anticholinergic drugs that we see prescribed frequently for sleep and other things. So I will talk a little bit about those if you want to go to the next slide.
Yeah, thanks.
So this is just kind of a list of things, when you're starting to look at somebody's med profile. just some points that really you want to look at. First, you want to look at what they're on, and are we using things to treat side effects that another drug might be causing. So what I like to do when I first look at somebody's med profile is really take every drug they're on, match it up with every diagnosis they have, and then make sure that we kind of have things matched up that way. And if we have a mismatch, then sometimes that'll be an easy way to kind of start looking at medication issues. Also just watch for meds that might be using to treat side effects. So one of the classic things that I think of, which it's not related to dementia, is patients that are on a GI medicine like an NSAID. They'll be put on a proton pump inhibitor to protect their stomach from bleeding. This might happen in an acute situation, like when they're in the hospital, but then that medication just gets continued forever and ever, never gets taken off their list. And so at some point, if you take a look and say, well, why are they taking this? And do they even need to be on it anymore? And then high-risk meds in the elderly. So everyone's probably fairly familiar with the Beers criteria, but I think that's something that somebody mentioned in chat as something that might be really beneficial to do some more education surrounding those drugs. So those are high-risk drugs in the elderly, and there's a huge list of them and reasons why we should be cautious using them, and then potentially other medications that we can consider as alternatives. There's also the stop and start criteria that some of you may be familiar with as well. And then really reassessing the need for chronic medication. So if somebody's in an advanced state of dementia and they're still being treated for high blood pressure, high cholesterol, and maybe these medications could have side effects that aren't really benefiting them anymore as far as managing their chronic disease, that's always something to take a look at. So this is a resource that I really just think is awesome. It's deprescribing.org, and they basically took a look at 5 common classes of medications and put out these guides for what we call deprescribing. So that is essentially defined as planned supervised dose reduction or stopping medications. And these algorithms kind of give you a guide on how to do this for different classes of medication. And this is when medications could be causing harm or they're no longer providing any benefit. And really kind of coming back to what Dr. Eisenberg said about just balancing quality of life and really putting that at the forefront of reviewing these medication regimens. So I posted this one. This one was the one for deprescribing the cholinesterase inhibitors. But there's also one for deprescribing antipsychotics, proton pump inhibitors, diabetes medications, and then these benzo-like or Z drugs like zolpidem that we use for sleep. So this is just the first page. They're each 2-page guides, and they can be accessed at the website at the bottom. There's also a really nice video that kind of goes through the process of deprescribing, what that looks like. It's about 8 minutes. So if you want to take a look at that, I think that's really good information as well. And on the next slide, I think I put one more. I think it was the antipsychotic. So you'll see it gives, the first page kind of gives this process of how do you discontinue or decrease the dose on a medication, and kind of step-by-step processing for that. And then the second page just has a nice comprehensive list of all the drugs in that class, considerations that you need to look at, alternative ways to manage specific, like in this one, it shows sleep management, other things that you can do non-pharmacology wise. Next slide, please. So this is a case study that I would love everybody to take a look at and just see what thoughts you have regarding CJ, a 68-year-old man with a diagnosis of Alzheimer's dementia, had some other medical history, hypertension, insomnia, high cholesterol, urinary incontinence, and depression, and then a medication list including Denepazil, lisinopril, simvastatin, oxybutinen, and diphenhydramine. So he is at an office visit. He's been experiencing some increased confusion reported by his son, and he's been having more trouble sleeping and just feeling a little bit more down than usual. Some lab values related to some of his drug therapy. And I would love to get your thoughts on what you think about the situation. Any first impressions or drugs that stand out to you?
Not being a medical provider, I mean, a doctor, I would need to know all those drugs, hit me was there's a lot of drugs and they sound scary, but I don't know what they're for. So I would want to know what they're for.
Okay, so yeah, that's that process that I mentioned, just matching them up with, what the indication is and making sure that everything on the medical history list, if there's a medication associated with it, and if there's not, is it something we need to address, or, is it something they don't need anymore? And if you want me to go through the list and tell you what they're for, I can certainly do that.
So here in the chat, okay. Oops, did you want to see this?
So I see somebody mentioned that Benadryl and Oxybutinen might be higher risk medications. Those are both medications that have high anticholinergic side effects. So we're kind of counteracting what's going on when we're trying to treat dementia. And those are both drugs that are listed on that Beers list that I mentioned. I think Benadryl gets used a lot and it gets missed a lot too, because it's available over the counter. So that was another thing that Dr. Eisenberg mentioned earlier, was that, it's really important to get the medications they might be taking over the counter too, because those can significantly affect their disease state and cause interactions and other issues. So the Denepazil is for the dementia that we talked about. Lisinopril is for blood pressure. Simvastatin is a cholesterol medicine. Oxybutinen is an anticholinergic drug used for urinary incontinence. And then he is using diphenhydramine. And he said he's been having more trouble sleeping. So maybe he's taking it more often, since his med list says he's taking it as needed, but it might be something for us to think about. And then he also mentions that he's feeling more down than usual. So if you're doing this process, kind of matching up the drugs, he's not being treated with any antidepressant drugs. So is that something that we need to think about, or we need to look at, or we need to investigate further from either a pharmacologic or a non-pharmacologic standpoint, of course?
You've mentioned over-the-counter drugs. What about things like the sleeping teas that are out there, to help with sleep? And
yeah, so that's a really good point, because some of those have like echinacea, some of them have valerian root in them, and valerian root does have some active pharmacology and can act actually similar to some of our like benzodiazepine drugs. And that can absolutely be a concern, and there are drug interactions to look at there as well. I don't know if they put melatonin in any of the teas, but that's another common one that you'll see over the counter. Does that answer your question?
yes, thank you.
And a lot of the sleep aids have Benadryl in them. I mean, if you look at multiple ones, they'll have different names and different strategies, but a lot of them do have that in them.
Yeah, thank you. I was just going to second what you said there around, you can be walking down the aisle at Costco or your local pharmacy, and there's all these PM medications or sleep aids. And it's over the counter, so it ought to be benign, but if it has Benadryl in it, it can really cause this confusion. So any of the PMs, the Tylenol PM, the Advil PM, any of those that say PMs on them, you want to be very careful to check for, or ask your, if the patient or the family are taking those medications.
I noticed that Denise had a comment back a little ways about the fact that as a caregiver, they're being left to depend solely on non-pharmacological techniques. And as a caregiver, and yet they're not given support to figure out which of these over-the-counter things. Because I know if I'm a caregiver, I'm going to be looking for whatever I can find. And if my doctors aren't helping me, I'm going to start trying out different things. And, that can be pretty dangerous.
Thank you. Yeah, no, I think that's, I'll comment, and then I would love you to. I think that's a very important point. And certainly as a caregiver, trazodone is an old, safe sleep aid antidepressant that can be used in the elderly with very good effects. Sometimes melatonin given 2 hours before, if somebody has a circadian disruption, can be used. And then Amber also added things like, bedtime routines, avoiding technology or noise. It should be, we talk about it should be dark, cool, and quiet, but of course we also sometimes do need things like trazodone or other non-harmful sleep aids.
This is Chris. Can I make a point about an earlier post as well? I've been hovering on Brian Schilling's post about, boy, it'd be lovely to have all assisted living or maybe adult family home staff well-trained. And the last I knew, Alaska was one of the few states that does not have any kind of mandatory training for, is that still the case or has that changed? It's still the case. I'm seeing some heads nod, and I think about when that changed here in Washington and in Oregon, where in order to have folks in your facility who have dementia, you have to undergo both kind of a basic dementia education as well as non-pharmacological training, because these things take training. They sound easy, but boy, they take some skills, and they take this kind of creative ability to modify them. So the idea of maybe petitioning at the state level that if you are going to be housing folks with dementia, you need to have training, and the state also then needs to roll out a variety of training programs that are evidence-based. And Oregon's got a lovely matrix of those. Washington has a couple as well. So I mean, something to think about. I know it's controversial and nobody likes mandatory training, but there have been some papers that look at state level requirements and how that drives change. So again, I didn't want to let that comment go by without touching on it. It's a big topic.
Thank you, Chris. It is a big topic.
I don't want to be the only person speaking, but it did bring up for me some instances that I've heard of about that. It's a big topic that sort of thing can happen. And I don't know what the answer is to it. I do know that in Alaska, at least the ones that I've been familiar with, is that these facilities that are taking care of people, they don't want to pay their staff. They don't have the funds. Let's put it that way. I'm not saying they don't want to, but it's more that they don't have the funds to pay their staff to attend trainings. And so it's left up to the staff to do it, or what they're given is, if they do any kind of training, it's a video if at the best, or a questionnaire that they have to fill out. And they do it once a year, if they're lucky. And they're supposed to answer some questions, or they might be told to read a book or do a book report, but it's totally voluntary. And it's, when we at ARA, we've tried to offer assistance, and I think it's getting better. People are realizing they need more than just those kinds of things, but it's still really hard to get these folks to open up their doors to us, to someone coming in, not just us, but someone coming in and providing training. I know we have a program that's doing that more, but again, if it's not mandatory and if there's not the funding support for it, these places aren't going to do it.
Right. And you need the training for administrators as well as staff, because staff rotate, right? There's a lot of staff turnover, and, you know, why would I work somewhere where it's mandatory, you know, if I could go work somewhere else where it's not? So it needs to be a part of a comprehensive package. And I just saw a lovely comment that, boy, this sounds like something that your Alaska Dementia Action Collaborative could tackle. So the gauntlet has been laid down for you.
Yes. You know, it can happen at multiple levels, at the policy change and advocacy level and at the grassroots level. And certainly part of our hope here, as we're all kind of raising our awareness together around this really complex issue, is how to have an impact locally, both in terms of the DAC and that type of advocacy work, and in terms of what each of you are doing in your own sphere of influence. Okay. So I'm going to now thank you all for your attention and say that we will, just to remind everybody, and maybe we could put in the chat that number again, please. And then just to remind everybody that we are going to meet in 1 week and for a talk by Carrie Rubenstein about multiple morbidities and dementia. And we'll see you then. Thank you all for your time and contributions.